Hello, my name is Dr. Amir Gharakani. I am the Director of Education here at Silver Hill Hospital, and I'm very happy to have you here for our grand rounds. We'll be having a virtual lecture by Dr. Ted Lawler, and the title is We're Not Here Yet. We're not there yet, but at least we're making progress. Before I introduce Dr. Andrew Gerber, who is our president and medical director here at Silver Hill, I just want to go over a couple of things with you. First, there is an opportunity to ask questions during the presentation, and they'll be addressed by Dr. Lawler at the end. There's a Q&A button located at the top right of your screen. Just click on that and submit your questions, and we'll try to get to as many of them as possible during the talk. Finally, if you want to get CME or other types of continuing education credits, please look at the Q&A under the tab Publish. There'll be a link that you can complete for attendance sign out and evaluation survey. So please fill that out and you'll get credit. So without further ado, let me introduce Dr. Gerber. Dr. Gerber?
Thank you, Dr. Gharakani. It is a real pleasure and a privilege to introduce Dr. Lawler today. I have a few thoughts, and I'll keep it brief because I want to get right to Ted's talk. But let me start by making an on-the-spot observation, which is that one of the things that I treasure about being a psychiatrist is the ability to be simultaneously positive, supportive, and also fairly cynical and aware of where the world could be better. And I want to start with the title because Dr. Gharakani made it slightly more optimistic than it in fact is. He said, we're not there yet, but at least we're making progress. But in fact, the title is, we're not there yet, but are we making progress? Because I don't think we know yet. And at least I'm looking forward to the talk today to hear Dr. Lawler's take on this, because I imagine, and I think I know from my experience with Ted, that he too has a realistic view of the world through his extremely impressive training and experience, but nonetheless stays optimistic in fighting the good fight. So let me back up now and tell you that Ted trained at University of Massachusetts in Worcester. I feel a kinship to from my past years in the Berkshires. We always thought of ourselves as the real Western Massachusetts because we were even further west than Worcester. But in fact, if you're from Boston, Worcester is plenty west. So from Worcester, he then went on to work for a good part of his career there as a psychopharmacology consultant, ECT therapist. He directed the psychopharmacology service at Worcester State Hospital, which many of you may know was a very, very important and significant place in the state health system in Massachusetts. And then also was the medical director, I believe, in Northampton State Hospital System. So really had a very major role there. He was the area medical director for the Massachusetts Department of Mental Health in DMH in Western Massachusetts. I worked with his successors there and know what a respected figure he was there. And that was all before he came to Connecticut. We were then lucky to have him move to our state, where he became the interim medical director for the Massachusetts equivalent of DMH, which is called, as many of you know, DEMAS, the Department of Mental Health and Addiction Services, where he came in 1997, and joined University of Connecticut Health Center, UCHC, full-time in 1999. Since then, he's been the director of public psychiatry at UConn, the mental health clinical administrator at York Correctional Institute, director of psychiatric adult clinical services, and director of outpatient services, director of medical student education, and associate medical director for the Department of Psychiatry. So he's really held many very important roles there. Since 2003, he's also provided psychopharmacologic services to inmates in the Connecticut Department of Corrections at night. And that's where I want to tell you the last piece, which is I got to know Ted because John Santopietro, the former president here at Silver Hill and now the director of behavioral health for Hartford Healthcare and the Institute of Living, organized, when COVID began, organized a Saturday morning call. And it really has been a tremendously important thing for me personally as every Saturday morning at 9 a.m., which I didn't think that would be a time I'd look forward to getting on a call, but it is, because I routinely get to listen to John and to Ted and to a few others from Connecticut talk about what they're seeing around the state and what they're doing. And one of the things that struck me right away as I got to hear Ted's voice was the passionate and dedicated way he thinks about individuals in this state, and individuals of all means and backgrounds, particularly those who have historically been neglected by the state. And by that, I mean folks in our correctional facility. And I don't know this from Ted saying this to me directly, because he's not one to ever tell you about his own accomplishments. But I have the sense that what he does for the inmates at night is just straight from his heart. And it is not for money, and it is not for, you know, they get paid something, but certainly that's not why he does it. It's not for prestige. It's because he cares deeply about people who have been left behind by the rest of the system. And I have a pretty strong feeling that that's what we're going to hear about in the grand rounds today. So thank you, Ted, for being with us, and I really look forward to your talk.
Thank you very much, Andrew, for that very kind presentation. And you hit the nail right on the head when you talked about my title, because I want to say that this is a more hopeful title than when I first spoke about some of what we're going to talk about today. But what we all hope that bringing something to light and making people aware of it might lead to change and hopefully improvement sometimes takes a while to happen. This is the title from 2014. And it's not working, so let me just do this. There we go. And you can see that the title is a little bit different. And what this is about really is primarily second-generation antipsychotics and what they have the propensity to do to people. But a number of us across the country that are public psychiatrists really began to advance the idea that second-generation antipsychotics are not what Big Pharma says they should be. So I guess I had a little bit harder edge 6 years ago, but now I have a beautiful little granddaughter, and I'm just a big pussycat. No conflicts to declare. And so what we worry about is metabolic syndrome. When we worry about it in general, but we worry about it with the use of second-generation antipsychotics. And metabolic syndrome is having 3 out of 5 of the following. You're overweight, and that's usually considered to be BMI greater than 30, and they represented by waist size. Your blood pressure is high, and when you look at those numbers, 130 over 85, you're probably saying, well, gee, it used to be 140 out of 90 over 90. And in fact, if you have some of the other components of metabolic syndrome, they want it even lower than 130 over 85. They want your fasting triglycerides. Oh, I'm sorry, that should be less than 100. Oh no, this is the syndrome, greater than 150. So they want you to be less. They want your good triglycerides to be 40 or better, and they want your fasting blood sugar to be less than 100. What are the medical issues that you're going to run into if you get metabolic syndrome? You're going to have an increased likelihood of cardiovascular disease. You're going to have type 2 diabetes mellitus. You have a higher likelihood of stroke. You're going to have fatty buildups in your arterial walls, and you know that that can lead to all kinds of problems in terms of your brain, your heart, your kidneys. You can blood clot excessively, and you can have different inflammatory diseases throughout your body. So one of the risk factors that we just talked about is your waist size. And when you look at the obesity statistics in this country now, we actually are in an epidemic, another one. Well, a pandemic when we think about COVID, but this is an epidemic. In 1985, no state had an obesity rate greater than 15%. And in 2000, no state had an obesity rate greater than 20%. Just 18 years later, and I can tell you that the statistics for 2020 are over 40% now, and we are really experiencing a rise in obesity in this country. And what the causes are, of course, multi-determined. They're not all second-generation antipsychotics, but the question I'm going to be asking of you, and I ask of myself, and I try to get the residents to understand that second-generation antipsychotics are prone to cause metabolic syndrome, and we should be very concerned about using them. So what are the health statistics by ethnicity or racial groups? We can see that if you're African American, you are going to have the highest rates of BMI, diabetes mellitus, and hypertension. Across the board, you're the loss leader. Asian non-Hispanics are high for hypertension. Their diabetes mellitus is high. Their weight, interestingly, is not. Hispanics across the board, Latinx, hypertension is 36%. Diabetes is 14.7. This is organized by diabetes. And BMI is second high. And white non-Hispanics, we are at 46% hypertension, which is high, 11.9% diabetes, and 42.2% BMI. So we have a problem with metabolic syndrome in this country. So we have to think about what we've done to ourselves in psychiatry. We actually began to separate ourselves from the rest of medicine about 2 centuries ago. And actually it was the opening of the first state hospital in Worcester State Hospital, where I worked part-time while I was at UMass Medical Center, opened in 1832. And what followed was a deluge, if you will, of state hospitals, because the prevailing zeitgeist a couple of hundred years ago and following that was to separate the mentally ill from the rest of medicine. And does anybody know when the first non-state dollar, because the state hospitals were 100% supported by the states, when the first non-state dollar, i.e. federal dollar, was spent on mental health care in this country, absent the VA hospitals? It was 1965. There was no federal money spent for mental health care until 1965, when the Johnson administration funded the Community Mental Health Centers Act that was passed in the Kennedy administration a month before he was assassinated. So it wasn't until that point that the feds got involved, but they very carefully made sure that none of the money that was being appropriated through the Community Mental Health Centers Act was spent on state hospitals, and in fact, they didn't treat the people in state hospitals in the community mental health centers. They did everything to avoid treating them, sadly. And the second issue related to what happened post-World War II was one of the important things that occurred in general for medical care was the rise of public insurance, and private insurance. And the Hill-Burton Act, which in building the general hospital system across this country, advocated for a mental health unit in every general hospital. All of this occurred after World War II. And those units had to take Medicaid money, but the private hospitals didn't take Medicaid money. So there became the continuation, if you will, of the public-private split. First continuation was moving everybody out 200 years ago, and then when the opportunity came to bring psychiatry, mental health care, etc., back into to integrate it with general health, it was continued to remain separate. So we actually started to think about rejoining with medicine about 30 years ago, perhaps as many as 40. What were some of the early impediments to reuniting? The general hospital units wanted to have nothing to do with the seriously mentally ill and the seriously and persistently mentally ill. Of course, they had to take some of the seriously mentally ill. In a few minutes, we're going to look at those two definitions, but they absolutely eschewed having anything to do with the SPMI, the seriously and persistently mentally ill, the difficult patients, if you will, the most difficult. And then, interestingly, although insurance companies did everything they could to strip people of their private insurance when people developed mental health issues that required repeated hospitalizations or chronic care in the community, and they, you know, when I became the medical director of Western Massachusetts in 1991, I used to fight tooth and nail with them, and I think I won about somewhere around 2% of the time, if I was lucky, because all they would do is somehow convince people, or the people were up against it enough that they could no longer afford to pay their premiums, and then they would fall on the state system. And the interesting thing was they take us away, take us away, take us away repeatedly, but when they brought managed care, they took away again, but they took away from the institutions, not so much from the individuals. They certainly took away to a certain extent from individuals, but when managed care came in, inpatient units saw a real drop in patients in terms of the numbers and the length of stay. And all of a sudden, around 1990, with the change in Medicaid rules, with the waivers, a number of states began privatizing, if you will, traditionally state hospital patients into general hospital units. So what were some of the attempts to integrate in the community that were all basically governmentally driven? First, we tried to place limited medical resources in the community mental health centers. Those were the mental health centers that Johnson funded in '65. And what did we do? We essentially put a nurse there. And we had the nurse screen people, take blood pressure and pulse, things like that. But for the most part, we didn't even draw blood levels or anything like that. We then began to place, again, limited mental health resources in CHCs, community health centers. So into the medical setting, and it was good that we were in the medical setting, but it was usually only one practitioner, and sometimes for a half a day or a day a week. So again, a very limited effort. Then we, with the establishment of the federally qualified health centers, we mandated behavioral health services. First, we mandated addiction services in the 1990s, when we established them. And then I believe in 2002, we added mental health. So these were all attempts by the government, but they were, I would call them half-hearted. But the first major attempt, and I'm going to talk about the next two, the health homes and the CCBHCs, occurred under the Obama administration. So Medicaid health homes were a collaborative care model for the integration of physical and mental health care, and of course this is in the community. They're one mechanism that can be used both to integrate primary and mental health care and to pay for the essential components of enhanced care management and care coordination required for effective integration. They were authorized by the Affordable Care Act, which is in danger once again, of 2010, Section 2703, and they are Medicaid health home state plan options, and essentially they were allowed to be either primary care based or community mental health center based. And primary care based means they're based in a medical setting, and you have care coordination and care management there. The fourth bullet is what you have in either setting: regular proactive monitoring and treatment using a validated clinical rating scale, and regular systematic psychiatric or medical caseload reviews and consultation for individuals who do not show clinical improvement. This program began around 2013, and these are some of the statistics that happened while it was open. In terms of metabolic syndrome screening, which is what we began this talk with, we got up to almost 90% in the last few years of this program. It wasn't, it sort of sunset the federal funding, which is no surprise with the administration that followed the Obama administration. But they actually, their screening got up close to 90%. In terms of, now you'll see that in this split screen that the CM is the CMHC is the mental health, and the primary care is the PCHH. You can see that the A1C levels, which are the measures of the 3-month measures of glucose in the body, dropped. Interestingly, in almost all of these, you'll see that the community mental health centers drop was greater than the primary care center drop. And you see a 21%, a 1-point drop is a 21% in diabetes-related deaths, 14% drop in heart attacks, and a 31% drop in microvascular complications. LD levels, this is cholesterol, the so-called bad cholesterol. Again, you'll see that they dropped over time in the health homes. The blood pressure measurements dropped, and the top is, of course, the systolic, and the lower is the diastolic. You can see that in the community mental health center settings, in that last year, 133 over 83 was actually getting people down below metabolic syndrome levels. And then the hospital follow-up, the changes in terms of ability to be in the hospital was decreased and dropped as these medical indices improved. And ER and hospital days, of course, followed in terms of the drops. In terms of the drop, the ER dropped by 34%, and overall hospital days dropped by 38%. And then the average number of ER and hospital encounters also dropped. And then cost savings for the primary care homes over the course was 7.4 million, and for the community mental health centers, there was a cost saving of 15.7. So essentially what this means is that because we provided care that followed both the physical health and the mental health parts of illness, we actually saved money. The way we funded these programs was that we increased the payments to make sure that these programs could provide this kind of care, and then at the back end we saw savings in terms of the reduction in the use of higher cost alternatives. The one that is trying to be refunded, and it ended in June of 2019, is the Certified Community Behavioral Health Clinic, the CCBHC. And it's, again, another Medicaid provider type. This was brought into being by Section 223 of the Protecting Access to Medicare Act of 2014, and it established a federal definition and created these programs. They're a new provider type in Medicaid. They must provide a comprehensive range of addiction and mental health services to vulnerable individuals while meeting additional requirements related to staffing, governance data, and quality reporting. They got a Medicaid reimbursement rate that covers costs. That's how, you may recall I mentioned the federally qualified health centers. That's how they were started. They are, I say, currently in operation in 8 states. They're trying to branch to the next funding source, which hopefully will occur with the next administration. And the reason why essentially they were brought into place was because despite the surging opioid crisis, only 1 in 10 Americans with an addiction receives treatment in any given year. Meanwhile, decades of funding cuts have left treatment providers struggling to hire staff and expand programs to meet the needs in their communities. Recent influxes of federal grant funding prior to this for some opioid-related activities provided critical support, but did not enable the comprehensive or long-term expansion in treatment capacity that was required. So they were enacted in 2014, and they were launched in 8 states in 2017. And what did they do? If they basically now 94% of the CCBHCs report an increase in the number of patients treated for addiction, either by taking on new patients, improving protocols to identify addiction among existing patients, or both. 17% of the CCBHCs have seen a more than 50% increase in their number of new patients with addiction. There's a reduced waiting time. In almost half, 46%, you can get same-day access. Another 16%, you can be seen within 1 to 3 days. And in a week, you can see 68%, another 16 in the 4 to 7 range. So there's a reduced waiting time for addiction care. For those of you who participate in addiction care, you know that this is very, very important, trying to get people in and trying to engage them in treatment as soon as you can. What are the required addiction treatment services? There has to be crisis care, 24-hour mobile crisis teams, emergency crisis intervention services, and crisis stabilization. Of course, these can be linked with the current mental health crisis teams. It's not so much that everything needs to be a new unit, it just is pushing integration. That's what the CCBHC is about. Integrating not only with physical medicine, but integrating within the behavioral health sphere as well, the addictions and the mental health components. You have to have evidence, you have to use evidence-based outpatient substance use services, addiction counseling, medication, MAT, addiction technologies, etc. Ambulatory and medical detox, treatment for occurring addiction and mental illness, screening, assessment, and diagnosis, including risk assessment for substance abuse, brief intervention and referral to treatment for problematic substance use identified during screening, peer review, peer recovery support, and family support services, treatment planning, including risk assessment and crisis planning, referral to outside providers for specialized substance use services, and targeted case management. So what have we seen? Launching and expanding addiction services lines. 100% of these CCBHCs report leveraging their status to expand the scope of their addiction treatment services. For many, these activities represent the first time such services have been available in their communities. We're facilitating the adoption of medication-assisted treatment. Medication-assisted treatment, or MAT, is a highly effective addiction treatment method that combines the use of medications with cognitive and behavioral therapies. MAT is the gold standard for opioid addiction treatment, with medications such as methadone, buprenorphine, and extended-release naltrexone consistently demonstrating positive patient outcomes. So you can see that in this slide, we've got the buprenorphine at 87% in CCBHCs, naltrexone 79%, and referral to outside programs for methadone 63%. The issue is to try to get these new services, to hire the providers within, couldn't be done under the old system. There was no money to do it. And then advancing the integration of addiction care. For an industry that has historically operated in a silo apart from the rest of healthcare, the CCBHC model represents a critical advance in coordinating and integrating addiction care. People living with addiction are at higher risk for co-occurring chronic physical health conditions such as hepatitis or HIV/AIDS. In many cases, a mental health condition may underlie or exacerbate an addiction, and addiction cannot be adequately treated. They partner with other organizations. They 35% partner with Recovery Community Organization and 8% partner with Recovery High Schools or collegiate recovery programs. They also, as you can see, make connections with hospitals, inpatient detox units, residential treatment providers. These are the groups you would expect them to link with. And they reduce hospitalizations by improving care transitions. People living with mental illness or addiction have high rates of hospitalization and emergency room visits. During and post-hospitalization represents a critical intervention period in which an assertive care transition strategy can help patients initiate or re-engage in treatment with the goal of reducing future hospitalizations. Preventable hospitalizations are also a major driver of relapse. So now we're going to take a little bit of a peek at the seriously mentally ill, because these are the groups we're talking about. What's the life expectancy? This is data from around 2010 to 2012. If you have no mental disorder in this country, at that time, your life expectancy was 78 years. If you have any mental disorder, which is about 20% of the general population, your life expectancy is about 66 years, about a 12-year difference. If you have any mental disorder, public sector, that's the SMI, serious mental illness, or the serious and persistent mental illness, your life expectancy was 52 years. the difference is usually considered to be 25 years. Decreased life expectancy if in this country if you have serious mental illness or serious and persistent mental illness. I'm sure that many of the people you treat have serious mental illness, and probably a good number have serious and persistent mental illness. And here's just a representation, and you can see that any mental illness at all is 19.3%, serious mental illness 4.6%, serious and persistent mental illness 2.7%. These are the definitions of those illnesses. SPMI is the presence of a mental illness. The duration is key to SPMI, and the impairment of function needs to occur in at least 3 areas. For serious mental illness, it's again the presence of a mental illness and the impairment of function in 1 or more areas. And the illnesses are, as you would expect, schizophrenia and other psychotic disorders, mood disorders, anxiety disorders, and personality disorders. This is one that many states struggle with. When I was in Massachusetts and we were determining eligibility, I remember the fight that we had over including personality disorders, and thankfully we won out. Interestingly, Connecticut still does not have criteria for its priority or target population for DEMAS. And when I came down to be the medical director for DEMAS in 97 and 98, which was a short and unhappy marriage because I talked about things like that. I talked about treating prisoners, and I was, I would say, not well loved, and deservedly so, I guess. So what are the functional areas? The activities of daily living, paying bills, using public transportation, maintaining a home, difficulty relating to others at work, in the family, social isolation, responding to environmental stressors, the changes, having difficulty adapting, problem solving, learning, etc. And then there's comorbid substance abuse. If you just take SMI, which is 4.3%, they have a 26.5% chance of having a concomitant substance abuse disorder. In comparison, if you take the general population, it's about 6.5%. So you have 4 times the risk if you have serious mental illness of having a comorbid substance abuse problem. Now we're getting back to other common comorbidities. If you see the red problems, heart disease, obesity, dyslipidemia, hypertension, and type 2 diabetes mellitus, what are you looking at? Metabolic syndrome. That is 60% of the morbidity and mortality for people with serious mental illness is caused by metabolic syndrome. What other problems do they have? And don't get me wrong, second generation antipsychotics don't cause all these problems, but you have to ask yourself, with people who have this higher propensity to have that type of problem, why do you want to give them something that's going to increase the likelihood of those problems? Because they do make poor choices. They're going to smoke even if they don't have enough money to eat right. They're going to use substances. They're not going to exercise. They're going to engage in, drug use, unsafe sexual behavior, and a lot of people live in less than desirable settings. They have higher rates of homelessness, victimization, trauma. I'm going to talk a little bit about trauma in corrections at the end. Unemployment, poverty, incarceration, and social isolation. This is, interestingly, this is data that I ran that because I and some others were really concerned about what the Community Mental Health Centers Act had really given us. And in 2000, if you were somebody who had been in the state hospital, 81% likelihood of your community tenure was you were either in a jail, prison, homeless, you trans-institutionalized into a nursing home, or you were still in a state hospital at 54,800. So I would consider an 81% failure not a very good job by the Community Mental Health Centers Act, and there are good reasons for that, but we don't have time to go into them. But let's just say that the people who presented the bill from NIMH never planned for them to care for the people from the state hospital, even though the testimony to Congress was they were going to take everybody they could from the state hospital so that the state hospital population could be decreased and they could be cared for in the community. This is a quote from Cicero, and it's "Oh the times, oh the customs," and antipsychotics, how prevalent is the AP use, and second generation antipsychotics, how prevalent is the SGA use, how targeted is the SGA use, and how justified is the SGA use. Here's the prevalence data, and again, this is old stuff. They don't have a lot of new stuff. If you look at the total expenses, you can see that it increased about fivefold, a little between 4 and 5-fold between 97 and 2007. You can see that the total number of purchases almost doubled between the same 10 years. The total number of persons purchasing one or more antipsychotics, again, came close to doubling in those 10 years. Now, here's the interesting change. SGA prevalence as percent of total AP use. 2003, 71%, but by 2010, 90%, and it's over 90% now. What's the FDA approved use of SGAs? Schizophrenia, bipolar disorder, not for all, but the ones that went out and did the post-marketing studies for approval, autism and only irritability in, and MDD as an adjunct to antidepressant treatment. The off-label use. It's all over the place. I won't read all these. You can just take a look at them, but the ones that I rail against are insomnia, anxiety, because we have enough other types of treatment, borderline personality disorder. I might say what medications do work for that. But here's how the off-label use looks. When you look at these huge administrative databases, 2003 Medicaid, 42 states, and the Department of Veterans Administration data from 2007, the off-label use of antipsychotics was over half. In other words, if you used an antipsychotic more than half the time, you were using it not for an approved indication. And 80% of that half was second generations. Now, if you want to look at the silver lining, that's not 90%, but still for off-label use, to think that we're over 50% is daunting. And so these are the questions I ask. Should they be used for FDA-approved indications? Should they be used for off-label indications? And should they be used in preference to FGAs, or should more than 90% of antipsychotics prescribed be SGAs? What will we promise that they would do? They were going to be superior in efficacy and safety. They were going to alleviate negative symptoms. They were going to improve cognition, improve mood, cause less EPS, and provide a better quality of life. Sounds like a pie in the sky. What have they delivered? And this is the bottom line. I'm giving it to you at the beginning of what and then we're going to figure out why this is true, less EPS in general. One of the 3 large government studies didn't find it, but the other 2 did. More metabolic syndrome in general. And then that clozapine, in every study, clozapine is superior to all others, and that's certainly true. Why the disconnect? Big Pharma promised us one thing. Why didn't they deliver? Well, all the early studies were industry sponsored. The technical quality was good. However, they were designed to obtain outcomes favorable to the sponsor. Just think of Abilify being a non-weight gainer. How did it get that reputation? It ran its, under Otsuka, the pharmaceutical company, it ran its trials for 5 weeks only. And then they reported, gee, people only gained 2.2 kilograms. Meanwhile, today, we see kids blowing up on Abilify. But in a minute, we're going to look at the 2019 third edition of the APA treatment of schizophrenia, and we're going to see that they snuck in under the wire again, getting a low rating in terms of weight gain. Design biases. Again, the favorable doses, the length of the trial were employed. They asked the right questions. In other words, they knew what the outcome they wanted was, so they molded the questions and ignored the questions that had anything to do with the problems that existed with their product. And the discrepancy between points of emphasis in the abstract and actual findings can contribute to reader perceptions of differential efficacy. And you learn that the marketing arm of the, just like the financial arm in insurance companies, the marketing arm in pharmaceutical companies has a lot to say about even how the articles that are produced, not the ones that the FDA reviews, but the post-marketing studies, how the articles that are produced tend to carefully shape and mold the findings. Not so much the numbers, but what the numbers mean. So here we have the graph from the APA 2019 third edition, and this is oral formulations, and it's first generations on top, second generations on the bottom, and this, the last 3, weight gain, hyperlipidemia, and glucose abnormalities. We're looking at metabolic syndrome components right there. So what I did was I reorganized these. Wait a minute, not this slide, sorry, the next one. But you can see that the first generations, if you pull them out so that you can look at them carefully, in terms of glucose abnormalities and hyperlipidemia, not much effect. That the weight gain is variable. And you have to remember that the first generations, they weren't just D2 blockers. They did have other receptors, some of them that they also had besides the effect on D2. And in a minute, we're going to go over what those receptors and peptides and genomes can mean in terms of metabolic syndrome. If you look down below, though, at the second generations, you can see that they're all over the place. For each of the weight gain, hyperlipidemia, and glucose abnormalities, there are lots of 2s and 3s in there because of their highly increased receptor blockade profiles. And here's the look at the receptors, the peptides, and the genotypes. The one that's clearly been elucidated is 5-HT2A, a serotonin receptor. It clearly results in feeding increases and impairment of insulin sensitivity. Impairment of insulin sensitivity is very important because with type 2 diabetes, if you can lose weight you can sometimes reverse type 2 diabetes. And often people have surgery in an attempt to do that. When you also have an effect that impairs insulin sensitivity, the ability of insulin to get glucose into the cells, there is question in the scientific community about whether that's reversible or not. And I don't think the answer is known yet, but from what I understand, there's significant concern. And then there's also substantial data for histamine, muscarinic, and adrenergic receptors. And again, with second generation, you have activity, depending on which medication it is, you have broad activity in those receptors. And the effects on weight gain may depend on that second generation's receptor activity profile. They also have activity with peptides, insulin, of course, being one, but ghrelin, leptin, glucagon-like peptide 1, etc. It also seems possible that part of the weight gain risk is associated with the patient's genotype. So you have issues with 3 areas. I always like to say that I get all of my information from Giants of Science comic books. I made it through college by reading Classics Illustrated. What can I say? So what has exposed the bias that was presented by Big Pharma? 3 non-industry sponsored studies, which is in Europe, and UFEST, which is in Europe. And so CATIE was an effectiveness study. And what's the difference between an effectiveness study and a drug company study, which has to, which involves efficacy? You use a real-world population, and you really want to find out, does the intervention work with that real-world population? And you don't exclude, pretty much you don't exclude anybody. You use the usual providers as the group that recruits study participants. And you apply the intervention with flexibility. You allow concurrent interventions, and crossover are permitted. So there's a big difference in the studies that were in the way CATIE was conducted. What were the CATIE outcome measures? The primary that they were looking for was the discontinuation of treatment for any cause. The secondary was inefficacy, secondary to side effects of any cause. They were looking for the negative symptoms and clinical global improvement differences, and safety and tolerability, including significant adverse events, neurological side effects, EKG changes in labs. The CATIE results: between all study medications, there were no significant differences in effectiveness. And CATIE included a number of SGAs and haloperidol. No advantages in efficacy with regard to negative symptoms or cognitive impairment. High rates of discontinuation across medications. Robust differences observed were only in rates of side effects, particularly weight gain, cholesterol, triglycerides, and prolactin. First 3, metabolic syndrome. Study medications are clearly effective for schizophrenia. However, they have substantial limitations in efficacy and safety, which lead to switching and adding other medications. There is a variation in effectiveness, which can be substantial for individuals. What works for one doesn't work for another, and thus the treatment needs to be individualized. CATIE impact, this was again from almost 10 years ago now, was the new med was coming out, was gaining. Quetiapine and olanzapine were down. I'm sorry, quetiapine was up. Olanzapine and risperidone were down. Clozapine was flat, same as it is now. And SGA use remains rare. So basically what that slide says is big pharma marketing works. The two new ones were kicking butt. Two of the older ones were dropping a bit because if you buy new ones, you don't buy the old ones. What else? Demonstrates the value and importance of independently sponsored and conducted comparative effectiveness trials. And it also provided for the creation of an infrastructure for the ongoing generation of information on comparative effectiveness. And PPACA established the PCORI to identify national priorities for research. Now this is the pushback. The use of the innovative outcome measure, time to all-cause treatment discontinuation, was not sufficiently specific or valid. The dose ranges of the study drugs were not equivalent. They're usually not in any studies. The study was not powered for inferiority. CUTLASS, the one that was based in Europe, quality of life was the primary outcome measure. Symptom improvement was the main secondary. Compare clozapine with, in CUTLASS 2, compared clozapine with other SGAs for symptom improvement. There was no advantage for SGAs on QOL. There were more first generations used in this study than one, or symptoms over 1 year. In fact, individuals taking FGAs did better on both measures. There were no significant differences in rates of objectively assessed EPS. This was the one that didn't find a difference in EPS. Individuals reported no clear preference for either class of medication. Clozapine showed, this is part 2, a significant advantage over other SGAs in symptom improvement. I think everybody accepts that. It was preferred over other SGAs significantly. UFEST. They looked at the one that was left, I guess, compare the effect of haloperidol and SGAs on the cognitive performance of individuals with schizophreniform disorder and schizophrenia. Compared with baseline scores, composite cognitive test scores improved for all treatment groups. There were no overall differences among the treatment groups. There was a weak correlation between the degree of cognitive improvement and changes in positive and negative syndrome scales, the PANS, etc. So then I ask, the questions before, should SGAs be used for SGA approved indications? And I think yes, but carefully. And I think they should probably be second line because of the medical problems they cause. I, for instance, will not order a second generation antipsychotic. Maybe once every year or 2 years. If I've seen the first generations fail, I'll consider and use a second generation, with the exception of clozapine. Clozapine and olanzapine are the most likely to cause metabolic syndrome, but clozapine, in terms of its clinical effectiveness, is head and shoulders over all other antipsychotics. And if I'm dealing with people who have significant impairment, usually they're SPMI because of schizophrenia, I'll sit down and have a talk with them, and I will give them clozapine, and usually, on average, you see a 70 to 80% chance of improvement where you haven't seen it before. And finally, for SGAs, I think it may be that schizophrenia only is the most appropriate FDA approved indication. And should SGAs be used for off-label indications? And so I quote a few of the dictums I think doctors should live by. We shouldn't do harm. And then from one of our oaths that we take, I think we need to heal ourselves. We need to pay more attention to the data, the evidence-based information, and just not get so many Chinese dinners and Italian dinners from the drug reps. They might make you sick. And I think that there's going to be litigation. And I work in corrections, and of course, you've heard the phrase clubhouse lawyer or clubhouse lawyers, but jailhouse lawyers. I guess there's both. These jailhouse guys, though, and they're constantly bringing suits. And so they watch television and they see Risperdal and they see Zyprexa and then they see some SSRIs, and they're wondering, how can they cash in? And it's you don't have much to do there, so you might as well think of something like that. But I think that there's going to be increased litigation. People used to worry about TD. I don't think there was a rash of TD lawsuits in the 80s and 90s, 100 and aughts. I know there were some, but I think we're going to see trouble with SGAs. And should the SGA-FGA ratio be greater than 9-to-1? Well, if you've got something to do with Big Pharma, it's a good thing. So let's take a look now at another problem with SGAs, and this has to do with emergency management, the administration of involuntary medications for the out-of-control, agitated, violent patient. So we're just going to look at this is again from the APA 2019 schizophrenia, third edition, treatment update. The last column is sedation. Now I did reorganize this top group so that you can see it now goes from, in terms of CPC equivalence, I added that column in, from low potency down to high potency. When thorazine is 100, the lower ones are all pimozide, trifluoperazine, haloperidol, and fluphenazine. The ones that are 2 at the bottom are high potency. When you look at sedation, you see that for the high potencies, the sedation is very low. And when you look at the mid-range, the 8, 10, 10, it's moderate. And then for the very low potency, 2 at the top, thorazine and chlorpromazine and thioridazine, they're very sedating. Take a look at the second generations. There's a complete violation of this sequence. And again, it's because of the receptor profile and the other things that have to do with, we've already seen diabetes. It also has to do with sedation. And so there is no rule really that you can follow with the second generations. And so what I argue in emergency situations is, if you have a psychotic patient that's violent and out of control, and you give them a second generation antipsychotic that's, let's say, mid potency, or you don't give them very much, you're going to put them to sleep. And you're going to put them to sleep for a few hours, and they're going to wake up and smack the hell out of you again. And it's because you didn't give them enough antipsychotic. So we were beginning to address this problem in the 1990s and just before the late 80s and early 90s, and there were 3 important papers. Davis's paper in '74 that came up with the idea of thorazine equivalence. Tupin's paper in '85, which came up, was called focal neuroleptization, and it was an approach to optimal dosing for initial and continuing therapy. And Dubin's paper, which was in '86, the pharmacotherapy of psychiatric emergencies. And they really came up with the concept of the hack. And you really should be thinking about that when you have agitated, violent, out of control patients, because what you want to do if they're psychotic is, that's a time when you can give them meds that will help their psychosis. Think about giving them enough. So along with those 3 papers, we have to think of Baldessarini's work that talks about what's enough antipsychotic per day to treat chronic or acute processes. And for the most part, you got somebody going nuts in your ER or on your unit, they're violent, they're out of control. I would call that acute. And so basically what they say is 300 to 1,000 thorazine equivalents a day. And so if you end up giving them A little bit of Zyprexa, a little bit of this, a little bit of that. You give them 50, 100, 150 Thorazine equivalents. When they wake up, they're going to be swinging. You give them haloperidol 10 IM, you just gave them 500 Thorazine equivalents. You give them, because it's not sedating, you give them some lorazepam. You better give them some Cogentin, of course. I once had to hack a patient that had an acute dystonic reaction when I was a third-year resident in a private psychiatric hospital. I had to trach him with a Bic pen because the doc had given him 10 milligrams of Haldol at 4:45 and left. And when I came in, he had his arms crossed across his chest. He was turning dusky, and he was in acute laryngeal tracheal spasm and was going to die. And they didn't have any tools to really do the job right, so I used my pen. You always have to, in anybody that has muscle mass, and you give them a high potency first generation, give Cogentin with it. Those are the papers. This is a table of antipsychotic and CPs, the chlorpromazine, Thorazine equivalents. This is a poster that one of our psychopharmacologists, he was a fellow at the time, began putting up in our outpatient department in 2011. And then I'd like to close this part by quoting from Bion. This was in Plutarch, The Lives of Famous Romans. Though boys throw stones at frogs in sport, yet the frogs do not die in sport, but in earnest. Though prescribers throw meds at patients in hope, yet the patients do not die in hope, but in despair. Working on the night moves. Here I am in prison. It's a great song, by the way. I wish I had the music to play for you. I've been there since 2003 to earn extra income, but I like it. And I found basically three things. Substance abuse is probably greater than 90%. Bipolar disorder is probably underdiagnosed, and PTSD is definitely underdiagnosed in males. What follows is about number 3 and how I serendipitously stumbled upon a diagnostic technique that Emily Post, aka the APA, would likely frown upon. This is observational data only. No formal scientific study was ever conducted. And I call what I do at night meatball psychiatry, so I recommend you adopt an appropriately skeptical stance to what follows. I've been there 13 plus years, since 08. I've treated 5,000 individuals for PTSD because especially at the beginning, I was able to see 15 or 20 at night. I was younger. And it was all medication management. They don't have anything else in DOC. And I have slowed down. I estimate that PTSD is the second most common diagnosis in Connecticut DOC, behind only substance abuse. It's not well diagnosed because generally only standard diagnostic techniques are employed. Everybody cover your ears. So I was shaving one morning and a light bulb turned on and I said, "You're white." Then I said, 2 out of 3 of the Connecticut DOC's patients are people of color, generally considered to be a third Hispanic, a third African American, and a third everything else. Are they really going to tell you their most shameful secrets and revealing weaknesses? I was congratulating myself for this epiphany until my wife pounded on the bedroom door and said, "Will you take your act somewhere else? I have to get ready for work." I immediately embraced heresy. I told myself that I didn't really need to know what caused the PTSD, just what the sequelae of the traumatic event were. I was really not fully prepared for what followed. So here's my PTSD question. I've taught it to every resident, and about 1 in 10 use it. I only want a yes or no answer to this question. I don't need to get into your business. About 10% of the inmates laugh at that line. "Oh yeah, you're a psychiatrist." Going back in your life to grade school, junior high, and high school, did bad or traumatic things happen to you? Or did you see them happen to somebody else? Now, just to let you know, I did have a third part. I used to say, or did you do them to somebody else? And all of a sudden I found out how many guys were innocent, so I dropped that one. And to finish, of a physical, emotional, or sexual nature, yes or no. And then if the answer is yes, I just say, tell me how you've changed. To end the suspense, I'll tell you that they essentially read out the diagnostic criteria from the DSM as they answer this question. I don't give them any leading questions, pretty much. I'll get to the pretty much in a minute, because sometimes they say, what do you mean? And I say, did you become different? And, you know, I ask one after another, and I try to get them to tell me how they changed. And then sometimes I say, any problems at night, you know? But again, this is a small percentage, maybe 20, 30% max. Most of them just roll the DSM out to me. They talk about a complete reversal of behavior in school, truancy, disobedience, disrupting class, and verbal and physical aggression. At home, they withdraw or act out, bully siblings, disobey, talk back, and refuse to go to church. They start to run the street, use substances, get in trouble with the law, fight, often with weapons. As a result of their problems and or their family's problems, they may be removed from the home. They describe insomnia, nightmares, triggers, and flashbacks. They try to avoid distressing memories and external reminders of traumatic events. They can display an impaired memory of the events, have persistent and exaggerated negative beliefs, have persistent distorted cognitions about the events, view life negatively, develop anhedonia, become estranged from others, and have difficulty experiencing positive emotions. They can hear voices. If you carefully examine the history of their voices, in many you'll find that the first voice was the voice of the abuser back in the day, and that's usually somebody who sexually abused them. I treat with medication only. I use clonidine. I use prazosin when clonidine doesn't work. And then I might add a clean SSRI. The first three, Prozac, Paxil, and Luvox, are dirty, tend to have side effects before therapeutic effect. And in prison, of course, you have a limited formulary, so I'm generally using sertraline or perhaps citalopram. I start with 0.1 milligrams BID of clonidine. I see them at 2-week intervals. They go nuts. They want me to see, just like every other prescriber, people every 12 weeks. I refuse. But of course, I got to see them fast, and I got to go over side effects. It's a strictly medical interview. I try to max that single agent to full effect. I aim to begin 0.3 milligrams BID by the end of week 4. I generally begin sculpting clonidine at this point. Usually the daytime symptoms respond earlier than the nighttime symptoms. So I usually see a split, more at night, less in the day. 80, so what were the results? I kept these by hand, and then I entered them into an Excel spreadsheet when I got back to work. 84% had some response in the first 16 weeks. 41% had a complete response. 80% completed the initial 16 weeks. You know, people are transferred or discharged and moving back and forth. So 13% were transferred or discharged before 16 weeks. 7% dropped out of treatment for various reasons. Daytime anxiety. What were some of the response characteristics? The anxiety symptoms usually responded first. Nighttime symptoms, usually nightmares, responded in terms of frequency, length of time to return to sleep, and intensity, generally in that order. Those I thought were the characteristics of nightmare response. Anxious awakenings without apparent NMs included tremulousness and or diaphoresis and or tachycardia. I conceptualize these as nightmare equivalents in the absence of recalled nightmares. I believe that there's a nightmare under there because when these types of symptoms appear, it's after I've pushed the nightmare down with a certain amount of clonidine. And then 0.1 milligram BID had a 5% response probability. And you can bet that I say to every patient, look, I'm going to see you back in 2 weeks. Just take this because it's a blood pressure med too, and I can't start you in the middle of the top, etc. So 0.2 BID has a 30 to 35% chance, and 0.3 BID has a 60%. After sculpting, I get to 75% with clonidine only, of which 37% is full. And when I add the SSRI, I get up to 85%, of which 41%. Let's see. At 1 year, there were 37% in treatment, and 170 of those 184 continued to have some benefit. I think I'm going to stop because it's time to stop and take questions. Thank you very much.
Hey, I hope nobody's mind. I'm going to add a little musical interlude as we wait for questions. You recognize that, Ted?
Yeah, I like that.
Little too tall, could use a few pounds. Tight pants, points, hollering out. She was a black.
Ted, there are a couple questions on there. I don't know if someone's read them to you or if you can see them.
I don't see them, and I don't know how to find them.
Why don't I read them to you? Oh, okay.
I can take over. First of all, Dr. Law, thank you for the talk. I thought it was an excellent discussion, and I actually want to say right off the bat that I've encountered this issue in my practice and at the hospital with patients receiving antipsychotics for things like anxiety. And I'd say anxiety is my strongest area of interest. And I can't tell you how many times people come in on olanzapine or quetiapine. And, I've looked at the literature, and there is obviously some positive evidence for using quetiapine, for instance, in anxiety disorders. But I don't think the patients are aware they're taking antipsychotics because the providers don't tell them. And so one of the questions I have for you before I get to the questions that other people have is, how much of a concern is this of people receiving medications from non-psychiatrists? Because I've encountered this a good deal where people are going to their primary care doctors and receiving prescriptions for things like quetiapine for insomnia or anxiety.
I don't know how often primary care doctors prescribe these medications. Hartford Corrections is an intake facility, and there are somewhere between 50 and 100 inmates that come in Monday through Friday directly from court or something like that. And if I'm running a clinic that night, I'm the only one there that is a prescriber, quote unquote, and they'll say to me, Dr. Lawler, we've confirmed these medications, would you order them? And I look at the medications, I don't really know anything about diagnoses, and then I commit heresy. I say, I have no goddamn idea what this conglomeration or mass is. I'm going to order these, and if you find out whether somebody's trying to treat anxiety, I'll give them Buspar and propranolol or something like that. So I can't tell you how many come from primary care, but the ones that I see, believe it or not, are from mental health prescribers, pretty much.
Thank you. So there is a question from one of our own staff, Dr. Murata, who works with a lot of the patients with primary psychotic disorders, and he asks, recently the cost of chlorpromazine has become prohibitive. This has forced us to use SGAs instead. It has also become difficult at times to get Haldol. Medication costs are rising. Do we have any other options that can help our patients, treat our patients at reasonable costs?
I've had a strange career. I think in my career, when I was a resident, I might have used, probably at the instruction of a supervisor, Thorazine. And I think in my whole career, that might have happened 5 times. And I don't think I prescribed Thorazine in the last 30 years. So I'm not really interested in the low potency first generations. And it turns out Thorazine, because of its receptor profile, is somewhere in the middle of the SGA group in terms of the problems we've talked about. Of course, sedation, but also metabolic syndrome. The mid-levels, profenazine, I hope that that's available. I certainly use it in corrections. And for some reason in corrections and at UConn Health Center, where I'm the chief, we have enough haloperidol and flufenazine that I can use those as well, and I can use them in corrections. So I don't have a very broad array of antipsychotics that I use, but when I use antipsychotics, it's the first generations and it's mid to high potency.
I want to hand it back to Dr. Gerber if he had any other questions, or we're still waiting for some questions to come in.
Thanks, Amir. So Ted, thank you for just such a thought-provoking and important talk. I remember back, and I think it was either 2004 or 2005, hearing Jeff Lieberman give a grand rounds on CATIE when he described the results very much like you did. I mean, you know, as I understand it, those original papers and even his original presentation seemed to say, and I remember sitting in the audience thinking, oh my God, this is really, you know, going to shake up the pharmaceutical world, and FDAs really are no better. And yet somehow the message got transmuted, and afterwards people would mention CATIE as if it said the SGAs were far superior. Am I remembering that right? I mean, what happened to the results, and how did it get twisted into something else?
You know, I think it was controlling the message, and so you were fortunate enough to have heard at least one time what I would consider to be the truth. But I remember going to large meetings at the, you know, the large meetings at the APA, and there'd be somebody up there talking about, let's say, quetiapine. And I'd listen to whatever the presentation was, and then I'd raise my hand and I'd say, isn't quetiapine anticholinergic? And they'd say, absolutely not. And these were all, they all took money from drug companies to do studies. And it went on for 3 or 4 or 5 years, and all of a sudden, thrown out into the marketplace was, oh, it's cholinergic muscarinic, not nicotinic. And it was like, well, you know, it looked like, tasted like, smelled like, you know, we were seeing the anticholinergic side effects all over the place. Why did it take you guys so long? Well, I talk with people who work in pharmaceutical companies, as I'm sure we're all, and I'm not talking about reps. I pretty much won't talk with reps. Although we did have a great program at UConn that we can't run anymore because most of the academic sites, programs won't allow drug reps in again. But for about 3 years, no, probably longer than that, I used to have one psychopharmacologist sit in, and the drug reps would bring their food in, and they could give a 20-minute presentation of the medication. And frequently outside would be the manager. It would be a new drug rep that would do it, and outside would be the manager, and they would get 20 minutes, and then they had to leave, and then the psychopharmacologist would lead a discussion about, you know, the 5 areas that drug reps were supposed to follow when they made presentations. And the rules were, if you went in there and took food, you stayed for an hour. Residents, medical students, APRNs, it didn't matter. You know, and I told them, if you don't want to stay, just don't eat the food. And we actually, the drug reps, they would ask if they could bring more people to present because they got feedback from us about how they did. So, but what I really want to get to is the people who work who are the PhDs and the doctors. Have a good friend now who's in Pfizer. Haven't talked to him for a while, but I think he'd be careful because he knows I'm crazy. But some of the other people will talk about learning about these receptors and what these receptors did, and they were put in under a cone of silence. They were basically told, you mention this stuff and you're done, and you'll never work in the pharmaceutical company industry again. And it's kind of rough, you know, to get your PhD. Maybe you've worked in neuroscience or something like that. If you're doing a mental health meds, you would assume they have. And to put them under that type of pressure, and they know these kinds of things and they can't talk about it. It's very bad.
I'm muted. I want to follow up with one question about clozapine, because you talked about clozapine, and it's a medication that we, you know, especially in the psychosis treatment programs, we've been using more often. And I don't know what your thoughts are about it, because I know there's a reluctance to use it because of concerns about monitoring white blood counts and about potential side effects. But obviously the data shows just how efficacious it is. And do you feel that there's too much reluctance to use clozapine, or to use it too late in people's course of treatment?
I think there is reluctance to use it for a lot of reasons, but I'll tell you my story. I graduated from training in '86, and clozapine came into this country, I think, within a couple of years. I'm not exactly sure. Connecticut put a $1 million line in its state budget for clozapine. Massachusetts, where I was, where I both trained and then started my professional career, decided to take the top 100 state hospital patients that were the sickest in the state hospital. And at that time, there were, I think, 4,000 patients. And they had 3 reviewers, and I happened to be the one for Central and Western Mass, and because I was interested in research. But this wasn't really research. This was just how do we give clozapine to 100 patients. And so we had a 100-point rating scale. We ranked the 4,000 patients, and we ended up with a cohort that had a 23-year average length of stay. They were, I don't think any of them were below 90 out of 100 issues in terms of symptoms, decreased activity of daily living, etc. What we found was, at the end of a year, 100 were discharged from the hospital. I'm sorry, 20 were discharged from the hospital. There were 100 of them, 20 were discharged, 20 more were close to being discharged, 20 more were clearly improved, and another 20 were somewhat improved, and 20 no improvement. So it's the Massachusetts State Hospital system, it's the 100 worst patients, and that's what we came out with. And I will give clozapine to anybody who has failed, if they'll agree to take it. And I understand that metabolically, it's the worst. It's tied for worst with the olanzapine. I understand that. But I will give clozapine if somebody wants it to try to improve their lives if they're that impaired.
Dr. Gerber, we're pretty much out of time. I just wanted to know if you had any other questions for Dr. Lawler, concluding remarks. I just wanted to say before I hand it off to you, please submit your survey under published in the Q&A section, and where you can get your credit. Dr. Gerber?
I don't have much to say. I just wanted to thank Ted for, I think, a remarkable talk, and for being the kind of doctor, not just psychiatrist, but the kind of doctor I think we should all aspire to be, someone who tells the truth and is brave enough to stand up even to some very powerful forces out there. So with that note, I'm going to end us with Ted's song. Here we let's see if I can get it going. There it is. Here we go.
Working on a night move. Trying to make some front page driving news. Working on a night move.
Thank you.
And the summer
Thanks, Ted.
Thank you very much.